Assalamualaikum and good day to my supervisor Dr. Noor Sam and my fellow friends. This is my orthodontic case presentation, which comprises of two parts, Part A and Part B. So for Part A, the patient given to me is MFW, male, born on 4th April 1995. He complained of malaligned upper teeth and wished for crown on upper left central tooth. For past dental history, 7 years ago, he had trauma on upper left central incisor with fractured crown and exposed pulp. The treatment that he has received is root canal treatment with composite filling. He has no significant past medical history. This is the extraoral pictures of the patient. The skeletal assessment is divided into three parts, which is anteroposterior, transverse, and also vertical. Anteroposteriorly, we could assess that the patient has a class 1 skeletal pattern and a straight facial profile. He has an asymmetrical face. As you can see, the right side of the lower jaw is slightly more prominent than the other side, and patient has incompetent lips. Patient has moderate Frankfurt mandibular plane angle and moderate lower anterior facial height. These are the intraoral pictures of the patient. He has fair oral hygiene, normal oral mucosa, there is mild supragingival calculus deposition. Patient had several carious teeth, and on tooth 2-1, there is composite restoration with discoloration. There is yellowish discoloration on the labial surface, on the junction between the tooth surface and the restoration surface, and there is also a dark discoloration on the plateau of 2-1. All teeth are present in this patient. Even at the lower third molar couldn't be assessed from the intraoral pictures. The teeth are present in orthopantomogram. This is the occlusal analysis of the lower arch. It has U-shaped. On the labial segment, there is moderate crowding of 5 mm. On the buccal segment, on the left buccal segment, there is mild crowding of 4 mm. There is displacement of contact point between 3-4 and 3-5 of 4 mm, and there is mild irregularities in right buccal segment. The upper arch is U-shaped. It has mild crowding of 1 mm on the labial segment, and there is increased proclination of the anterior teeth. On the right buccal segment, there is mild crowding of 2.5 mm. There is displacement of contact point between 1.4 and 1.5 of 3 mm. There is displacement of contact point between 1.5 and 1.6 of 2 mm, while there is mild irregularities on the left buccal segment. For the inter-arch analysis, on the labial segment, the lower midline is shifted to the right by 1 mm, considering that the upper midline coincides with the facial midline. Patient has class 1 incisor relationship. The overjet is within the normal range. The overbite is reduced of 20%, which is measured on tooth 2-1 to 3-1. There is anterior open bite involving teeth 1-2 and 1-3 to tooth 4-2 and 4-3. There is anterior crossbite involving tooth 2-2 and 2-3 to lower 3-3. On the buccal segment, the canine relationship is class 1 bilaterally. For the molar relationship, it is class 3 half unit on the right and class 3 3/4 unit on the left. The pre-treatment IOTN for the patient is 4D due to the displacement of contact point of 4 mm between tooth 3-4 and 3-5. There might be a discrepancy between RCP and ICP in this patient if it could be assessed. Okay, so the IOTN could be 4C, but because we couldn't assess the discrepancy in this patient, so I put the IOTN as 4D. Next is the radiographic investigation of the patient. First is the orthopantomogram of the patient. It shows that all teeth are present In tooth 2-1, there is radial opacity in the canal space and the crown, suggestive of restorative material. And we could see there is impacted 3-8 and 4-8. Next is the periapical of 2-1, showing teeth 1-1 to 2-2. There is radial opacity in the canal space and the crown of 2-1, suggestive of restorative material. There is slight widening of PDL space at the apex of 2-1, and there is no periapical pathology. This is the lateral cephalometry of the patient, and after tracing, this is the analysis that we could retrieve from the tracing. For the SNA value, it is reduced, so it indicates that the maxilla is retruded. The SNB value is increased, which indicates that the mandible is prognatic. The ANB is -3 degree, showing that the patient has a class 3 skeletal pattern. The SNMSP is within normal range, so patient is eligible for ANB correction. The MMPA is within normal range. The upper incisor to maxillary plane angle is increased, which indicates that there is increased proclination of upper central incisors. Lower incisors to mandibular plane angle is reduced, showing that there is increased retroclination of lower central incisors. The interincisal angle is reduced, and the lower anterior face height is moderate. So we've come to the summary of this case. Patient is a 25 years old Malay male, came with a complaint of malaligned upper teeth and wish for crown on upper left central tooth. He presented with class 1 malocclusion and class 1 skeletal pattern with moderate FMPA. There is moderate crowding on the lower labial segment and mild crowding on the lower buccal segment. There are mild crowding on upper labial and buccal segments. In occlusion, he has reduced overbite of 20%. There is anterior open bite from teeth 1-2 and 1-3 to teeth 4-2 and 4-3. There is cross bite involving teeth 2-2 and 2-3 to lower 3-3. Lower midline is shifted to the right by 1 mm. Canine relationship is class 1 bilaterally. Molar relationship on the right is class 3 half unit, while on the left is class 3 3/4 unit. The etiology in this patient is skeletal pattern and also dental alveolar discrepancy. So this is the problem list of this case. First is fair oral hygiene. Next, there is moderate crowding on lower labial segment, mild crowding on lower buccal segment, mild crowding on upper labial and buccal segment, reduced overbite of 20%, anterior open bite from teeth 1-2 and 1-3 to teeth 4-2 and 4-3, cross bite involving teeth 2-2 and 2-3 to lower 3-3, lower midline shift to the right by 1 mm, molar relationship is class 3 half unit on the right and class 3 3/4 unit on the left. So the aims of treatment in this case would be to improve the oral hygiene, to relieve crowding on lower labial and buccal segment, to relieve crowding on upper labial and buccal segment, to correct overbite to normal range, to eliminate anterior open bite, to eliminate cross bite, to correct lower midline shift, and to correct molar relationship to class 1 bilaterally. For the treatment plan of the patient, for phase 1, neo, for phase 2, scaling and polishing, oral health education and instruction, and restoration of caries teeth. In phase 3, we refer to orthodontic department for fixed appliance with extractions and Hody retainer, and refer to prosthodontic department for construction of crown on tooth 2-1, and fistful will be reviewed. For part B, the case given to me is a 15 years old Malay lady complained of upper front teeth are not aligned and overlapping. She presented with 5.5 mm overjet, which is increased, and overbite of 20%, which is reduced. These are the intraoral features of the patient. On the upper arch, there is mild crowding on the upper labial segment. There's mild crowding on the left buccal segment, and there's mild irregularities on the right buccal segment. Now for the lower arch, there is mild irregularities on lower labial and buccal segments. So the treatment plan for this patient would be in phase 1, nail, in phase 2, scaling and polishing, oral health education and instruction, restoration of caries teeth. Phase 3 will be construction of upper removal appliance with enamel stripping, and phase 4 will be review. I am required to design an upper removable appliance to align the upper labial segment. So this is my proposed design. It has labial bowl extending from 1-3 to 2-3 to reduce the overjet. It has Adams clasp on 1/6 and 2/6 for retention of the appliance. The appliance has a posterior bite plane extending from the first premolar, which is 4, until the last erupted molar. This is to disengage the occlusion on the labial segment and allow eruption for the overbite correction. And lastly, it has an acrylic base plate connecting all the components, and also to be the anchorage for teeth movement. So that ends my case presentation today. Please visit the discussion section if you have any questions or comments. Thank you.